So I want to briefly talk about a case that I worked with, the case of Charles. Charles was a 41-year-old male. He was married. He had a teenage daughter. He grew up in a home with an abusive family and a doting mother. When his mother died, when he was an adult, he shifted his dependency from her over to his wife. His wife was unfaithful in the marriage, and when that happened, he was devastated. He attempted suicide by overdosing on his medications. He was hospitalized for continued suicidal ideation with the intent to die. He really wanted to die. He just could not imagine life without her. And he was referred for outpatient therapy, which is the point at which I met him. So the beginning of my conceptualization with him was documenting in the relevant background information, the information about his abusive father, doting mother, and the relationship that he had with his wife and the impact that her infidelity had on him personally and on the marriage. So for him, a specific situation was learning about his wife's infidelity. It triggered the automatic thought, how could she do that? I can't live without her. He was very angry and devastated, and he then began to prepare for suicide. His safety plan included things such as this. The warning signs were recognizing the loneliness, the abandonment feeling, being taken advantage of at times by her and even his daughter, and reminders of his wife's infidelity are all things that would be dangerous things for him to be dwelling on. Things that he could do on his own included watching sports on TV, going for a drive in his car, reading about world history, or actually working. People that he could involve in social situations without really talking about what he was going through included doing things with his daughter, going to the bowling alley, or going to the gym to work out. People that he could actually ask for help included his cousin. Now, this was a very short list of people that he had, and he wasn't able to rely on a lot of people. So this was something that he actually needed to work on during the course of treatment. But in the very beginning, his cousin was one person that we were able to identify that he could go to and ask for help if he was really struggling. And we identified professionals as primary care physician, crisis intervention services, emergency department, and myself as resources when he was really in trouble and needed some strong support. And for him to make the environment safer, there was a switch from his benzodiazepines, which he had overdosed on, to using SSRIs. An important point about this is he tried to overdose using benzodiazepines, and with those alone do not oftentimes end up in death, but they do cause a significant degree of drowsiness. But if they're used in combination with alcohol or some other drugs, they certainly can be very lethal. And so we thought it better to have him switch in consultation with his physician to switch to using SSRIs. And not least of all, the benzodiazepine was probably not doing much for his depression anyway. In the middle phase of his treatment, we worked on skill building that included interpersonal skills to avoid resentment of people taking advantage of him and to change his belief that he was helpless and not able to do anything about his circumstances. We evaluated his core belief and his automatic thought that I can't live without her. We did a cost-benefit analysis to evaluate the relative merits of staying in or leaving his marriage, and worked on his lifestyle to give him better control over his emotions through using exercise, developing a more regular sleep pattern, and a more regular sleep pattern and exercise, and a healthy diet.